Go.
Hi, this is Erma Grego from Senior Perspective. Today I have something very different to share with you. One day last summer I was working in my garden and fell. The doctor said my hip bone broke, causing me to fall, which led to a hip replacement. Thanks to my guests and their staff, I am able today to walk and live a normal life. My guests are familiar with cases such as this. They are Dr. Mutschler from Southwestern Orthopedic Association and Antonio Zuloaga from Keystone Rehabilitation Systems. I have a few simple questions I would like to ask you. Could you tell me what is arthritis?
Remember, what arthritis is basically is a wearing of the joint surface. Cartilage is a very smooth and slippery substance. We don't have materials as slippery as cartilage on cartilage. And what happens is the cartilage, the actual running surface to the joint, becomes damaged. Originally it looks very shiny, pearl-like. As it starts to become arthritic, it softens, and it then becomes fuzzy. And then it starts to look like little pieces of crab meat as it starts to flake off and fall off. Once that surface is gone, the bone then starts to rub on the bone. That whole process is what arthritis is.
Well, is that what causes the pain then, is when that wears off?
The pain is caused by the particles flaking off. They irritate the lining to the joint, and the joint ports out a lot of fluid. Mm-hmm. And that's what you see as water on your knee.
Oh. So now would arthritis be hereditary?
There are two types of arthritis, rheumatoid arthritis and osteoarthritis. Rheumatoid arthritis is definitely hereditary. Those are the people you'll see where their fingers tend to drift and deform. That is hereditary. It can happen at some very young ages. Osteoarthritis can also be hereditary, but it's not as strongly linked. And what we think is that a portion, maybe about 6% of osteoarthritis, is familial or hereditary. And what that osteoarthritis is a wear and tear type of arthritis. That's how we tend to think about it.
Mm-hmm. Would that also be like some of the symptoms of getting arthritis, or are there something else that show the symptoms?
Well, symptoms of arthritis, how does a person know that they're becoming arthritic? What happens is you wake up in the morning, you notice your joint's a little bit stiff. And if it's a joint you can see, such as your finger joints or your knee joint, you might notice it's a little more swollen than the other side. It'll ache when you try to move it. Sometimes if you try to walk on it, you find you can't. It's just too sore to do that. And sometimes in the case of a rheumatoid arthritic, as the day progresses and the joint gets more mobile, they actually feel better. An osteoarthritic, on the other hand, as they get through their day, they actually feel worse at the end of the day. Mm-hmm. But those are some of the signs and symptoms. If it's a hip arthritis, what you might notice is that you're having more trouble putting your socks and shoes on because you can't bring your foot up to the position that you used to. Mm-hmm. Also, if it's in the lower extremity, such as the knee or the hip, you may notice that you're starting to limp. Or maybe your friends will tell you that you're starting to limp.
Mm-hmm. How can you prevent a joint from deteriorating?
Well, in the case of rheumatoid arthritis, there's various medications that tend to quiet down the process. In rheumatoid arthritis, the actual problem starts not with the cartilage surface, but with the lining to the knee. That lining tends to overgrow the cartilage and kills the cartilage. In an osteoarthritic situation, it's a fraying away of the cartilage. And you really can't do anything about that process. It's progressive, it's degenerative. There is recently in the news media and the like cartilage transplantation, and there's some research going on both in England and in the United States to see if we can regrow cartilage. The trouble with cartilage is probably one of the slowest growing materials or tissues in the body. And once damaged, if the wear process is faster than the repair process, you'll have arthritis. So basically the ability of cartilage to repair itself is limited, and the research into transplantation and along those lines is trying to find ways to help cartilage repair itself. That's cutting edge. That's not something you can do now. Basically, the approach to arthritis now is controlling the symptoms. If we can't halt the process, then we try to control the symptoms. There are some things that a patient can do to help. One of the things is if you're enjoying impact activities, if you like to run or play tennis, and you notice that after you do these things, your knee swells and it's painful and you're limping, then maybe you ought to stay away from those activities. There are other things the patient can do to help themselves out. Local things like a cane. They can use ice. There's numerous anti-inflammatory medications. The latest on the market are Aleve and Oruvel and numerous brand names. They're all basically about the equivalent. Some work better than others in some people, so you have to find the one that works best for yourself.
Would that be something like an aspirin or something, or is that something a little more stronger? Or?
Well, there's two different ways to fight inflammation. There are what we call non-steroidal anti-inflammatory drugs. You may have seen the word NSAIDs.
Yeah.
And then there are steroids, and everybody has a bad feeling about steroids. The truth of the matter is non-steroidal anti-inflammatory drugs work via a different pathway in the body to relieve inflammation. Their side effects are mostly gastritis, upset stomach, and if you're on them for prolonged periods of time, months and years, you have to be concerned about any sort of kidney damage. Steroid medications, on the other hand, work by a different pathway. And because of the abuse of athletes and that with steroids, people tend to shy away from them. But they're much stronger than the non-steroidal anti-inflammatory medications. You tend not to stay on them for a long time. In addition, sometimes you can locally inject the steroids. Sometimes when you come into the doctor's office and your knee is puffed up and swollen, he'll tap your knee and then inject your knee with cortisone. And that can work very effectively. Fairly quickly, in 2 or 3 days, your pain can be settling down, if it's an accessible joint like the knee.
Mm-hmm. Yeah, I know.
You've had that experience,
Thanks to you. Now, if conservative therapy fails, can anything else be done?
Once a patient has tried conservative therapy, and that is a number of months of different anti-inflammatories, a cane, but you can't seem to convince anybody to use a cane these days. Why is that?
Well, I thought it was fashionable.
Oh, okay. Maybe we need to get that back into fashion, but canes will help unload the joint. If all this fails and the patient is still miserable, they're not sleeping at night, they can't do the activities that they want, then you have to consider a joint replacement as an option.
Mm-hmm. So, what happens during a hip replacement?
Let me show you what arthritis looks like to a surgeon when he's evaluating you to determine whether or not you're a candidate or if a hip or knee replacement will help you out.
Okay, that would prove interesting.
Okay. What I have here is an x-ray of a patient that has a normal hip and an arthritic hip. Okay. If you look at this side of the x-ray, and just limit to this side, you see this gap right here?
Yeah.
From here to here. That's the cartilage space. So halfway between that space is the imaginary line. We can't see it on x-ray, but where those two cartilage surfaces are rubbing against each other. This half is lined with cartilage, and the ball half, or femoral head half, is lined with cartilage. So that makes a very smooth, slippery ball joint, which essentially is what your hip joint is. Now let's look over to the right side. You notice the difference. That space is gone entirely.
Yeah.
Okay. In addition, we can see that this is really white in here compared to the other side. That's what we call on x-ray sclerosis. What it means is that the bone, because the cartilage is worn, is seeing stress unevenly now, and the bone reacts to stress. So it's growing up, it's building itself up, trying to fight off this increased stress. Mm-hmm. The other thing is, I don't know if you can see well, but see these little blackened areas in here?
Yeah.
Those are bone cysts. Okay, there are cysts that form in the bone as it's overloaded. And also, see how this is round?
Yeah.
You see how this is flattened out across here? And there's also a little bit of bone spurring going on.
What stage would you say that was there, the one on the right?
The one on the right, I'd say what I usually like to look at in arthritic terms is a mild arthritis, a moderate or severe arthritis. I would call this a severe arthritis. If all conservative measures fail and this patient is having pain that can't control and they can't live with, then the patient's only option is a joint replacement operation. The main thing to realize if you have arthritis is, I tell all my patients this, there's 3 reasons to have a joint replacement. Number 1 is pain, number 2 is pain, number 3 is pain. Because what can happen, some people decide to live within their restrictions. If if they decrease their activities, if they decide all they want to do is go to church, go to the shopping center for groceries and come home, and they have an x-ray that looks like this, but they're not having that much pain, you don't do a hip replacement on them. If there's somebody that likes to walk the mall, they've been doing 3 miles a day, and their arthritis is so bad now that they can't do it anymore, and they really want to do it, that's an excellent candidate for a hip replacement because they will get pain relief and it will restore them to the activity level that they're used to.
Well, the longer they wait, though, the more damage they do to that
It's a
hip, right?
progressive process, so it's really the more pain they're living through, not more damage, because we couldn't reverse the process anyway. So what they're doing is actually the wisest thing. Nothing beats Mother Nature. You ride it out for as long as you can, and when you can't stand it anymore, then that's a good time to have a replacement operation.
Mm-hmm.
Let me show you. I have an x-ray of a hip that's been replaced. Okay, now we can compare the two side by side right here. This would be the situation before the operation, and this is the hip replacement. What this is composed of 4 different components. This part here is called the acetabular side, and that's the old Greek word for cup, acetabulum. That's what we call this area of the pelvis. So this component is pressed in to the pelvic bone after it's prepared during the operation. You can't see, but inside of here is a plastic liner. Then there is a cobalt chrome or a ceramic head fitted on a titanium stem. So this goes down into your thigh bone or femur. This part goes into your pelvis. And then what holds it together? The muscle forces. These two aren't attached. I actually have some components we can look at.
Okay. May we see them now?
Sure. This part is the stem. Okay.
That's that long,
Yeah, this part
that goes into your bone?
is the part right here. Now the x-ray is a little bigger. Okay, it's magnified some, but this is this component. This goes down into your thigh bone. Okay. The implant that I tend to use has a coating on here. It actually has a bone mineral called hydroxyapatite. It's the mineral base that your bone transforms into. And what this implant does is the bone sees that and grabs onto it fairly quickly, chemically in about 6 weeks.
Oh.
So it gives, in my experience, a good fit with the bone. All right. Onto that, and this is a ceramic head, we place this ball, all right? And that composes your thigh bone, if you will, half of a total hip replacement. All right? Now, on the other side, we have this cup, which is titanium. You can see we have the inside polished, and that's because you're trying to prevent wear debris. Inside of that snaps this plastic liner. So surgically, after this is embedded in the pelvis, what we do is align this, and this will snap into place. Okay. Now you can see this is the plastic that rides on the ceramic head in this case. So now you have a joint that moves about. So see, neither piece, other than these two components, once these two are assembled, the only thing that keeps this pushed together like this is the muscle forces. So it allows you to walk and move your hip about without pain because the cartilage surfaces are now gone.
So the white part there is what takes place of the cartilage then?
Yes. That cartilage and this ceramic are now the new bearing surfaces. And this is basically where the weak spot is in joint replacement these days. This plastic wears, and your body doesn't know how to handle the wear debris. And when your body doesn't know how to handle something, be it tuberculosis, polyethylene plastic, it creates inflammation and tries to wall it off. And that inflammation eventually starts getting to the bony interfaces here and will loosen them. And after years, you'll start to have pain again. Basically, you can expect probably somewhere between 10 and 15 years out of a hip replacement. Okay? So the older you are, actually the better it is for you because, number one, your demands are a little lower. If we put these in young patients, they're basically the worst group to put them in, if you will. We just don't have the technology to date that we can replace a hip in a young patient and have it last a lifetime. We'd like to get there. We're just not there yet.
Dr. Mutschler, could you tell me where these parts, or whatever they're called, are made?
We call them components.
Components,
Parts is also
okay.
another name. These are made actually quite locally. They're made by Dynamic Corporation in McMurray, PA. There's a company, Stelcast in Pittsburgh, that basically is the distributor for these implants, and they're the people that you interact with when you're trying to get the patient, the components, together in the hospital.
Mm-hmm.
So it's really basically a Pittsburgh-made hip.
Thank you for the interesting discussion of the arthritis and hip replacements.
Thank you, Erma. I appreciate it.
We will be back to discuss with Tony Zuloaga of Keystone Rehabilitation Systems the routine necessary to return a patient to their prior active state.
Okay.
Who is that swimming?
Doing good, Al.
I'm swimming.
Try to get your legs up.
Like this?
Your legs up.
That's the way. Where's your kicking, Al?
That's right.
That's it. I'm almost there.
Okay.
I'm almost there, Mommy. I'm almost there. Whoa, you made it all the way.
If you don't stop your friend from driving drunk, who will?
Good job.
Do whatever it takes.
Good time?
Yeah.
I'd like to introduce you to my other guest, Tony Zuloaga, and he is from the Keystone Rehabilitation Systems, and I would like to ask him a few questions.
Hello, okay.
Okay, the first one would be why is physical therapy and rehabilitation important after a total hip replacement?
Well, as Dr. Mutschler mentioned to you previously, patients that require a total joint replacement usually have had arthritis for a certain amount of time, usually years. So during that time, they have had to decrease their level of activity. Therefore, they are walking less, they are moving less, they are doing less impact and non-impact activities, and therefore the joint flexibility, the strength in the muscles begins to deteriorate. So after the surgery, the patient needs to recover the strength, the flexibility in the joints, not only the affected joints, but also the other joints in the body that have been in disuse.
Mm-hmm.
So for that reason, they need physical therapy to go back to their normal functional activities.
Mm-hmm. How soon does physical therapy start after surgery?
Most of the time, and however this depends on the surgeon, but most of the time they will begin the day after the surgery with the physical therapist in the hospital, in the patient's room, assessing flexibility, strength, and the ability of the patient to be able to sit, to stand, to walk, and then determine what kind of treatment they will be requiring.
I remember those.
Sure you do. You have two of them already.
Right, and it wasn't, when they came and told me they were going to start me walking, I said, but they did, and I did. So, will the patient be using any assistive devices, such as a cane or walker, crutches, or anything?
Again, that will depend mostly on the surgeons after the surgery, and also in the ability of the patient prior to surgery. Some patient may have been using a cane or a walker for years before, and it will be difficult for them to go from using a walker for years to not using any assisted devices. So, and again, that will be depending on the assessment by the surgeon and by the physical therapist after the surgery.
Okay, are there any precautions or restrictions that a patient has to follow after a total knee replacement or hip replacement?
Especially after a total hip replacement. Okay, when they place the hip, and as Dr. Mutschler showed in his model there, that joint is sustained only by the muscles. It's sustained in place only by the muscles. So, particularly with the hip joint, there are certain movements that should not be performed by the patient following the surgery. And there are three main activities that the patient should avoid. The first one, they should never bend the hip more than 90 degrees. So therefore, they should not go beyond the knee level with the hip, bending it, which means they should also not squat, because that would bend the hip more than the 90 degrees that are accepted. And for the same reason, they shouldn't sit down on very low or very soft chairs or couches. And if they don't have any other thing, they can just put a couple of pillows and make the chair a little higher So the hip bending will not be more than 90 degrees. In other words, the knee should never be higher than the hip when you are sitting or when you're doing any activity. Another activity that should also be avoided is crossing the operated leg on top or behind the other one, or letting it get too close to the other one when you're lying in bed. If you're lying on your side, you should always put a pillow between your legs, between your knees, to prevent them from falling and crossing over the other one. So basically, don't bend the hip more than 90 degrees, don't do any squatting activities, and don't cross your legs. Those are the main restrictions.
Yep, I remember those. Okay, what type of exercises will a patient go through?
They will go through different exercises beginning in the, after the surgery, with some exercises to stimulate and improve circulation in the area, to improve flexibility, and then progressing to strength, balance, and conditioning to send them to their functional activities. But I think the best thing we can do now is maybe show with you as a model a couple of the exercises that are done with the patients.
Okay, let's see what we can do.
One of the first exercises we teach the patient, is this is usually done in the hospital, is exercises to promote circulation to avoid blood clots developing in the leg. And what we show the patient is to do what is called ankle pumps, and they just need to move their foot back and forth and then making circles around in one direction and then in the other one, and they will stimulate the muscles to work and pump that blood towards the heart, so there can be good circulation in the leg. And the patient will do these exercises several times a day to promote good circulation.
Something so simple, and yet
very simple,
it
but
works.
very important in the beginning especially. Then other exercises that will also be done in the beginning are flexibility exercises, to start gently moving that joint to stimulate the lubrication of the joint and the joints in the leg, and at the same time to begin movement of the muscles. And this will be done with assistance in the beginning, because the patient will be unable to do it in most cases by themselves. In addition to the flexibility and the circulation exercises, we'll also start with some strengthening exercises to regain the strength in the muscles that are deconditioned or affected. And one of the ways that we do that is using progressively increasing weights. In this case, we have her with a 2-pound weight, where she's going to start doing some exercises with her knee to strengthen the quadriceps muscles, which is the muscle in the front of your thigh, which is very important for walking as well as for balance and stability of the hip and the knee. From the exercises that we're doing in the mat before for flexibility and strength, then we progress you through whole body exercises where we involve more than just one joint, and that helps you with strengthening of the whole body as well as with some conditioning of your body, some cardiovascular exercises to improve also your endurance. And in this case, we're having her do some squats in a recumbent position. Therefore, there's only a percentage of her body weight being lifted back and forth. Can you do that for me? And here we can see how she works the hips and the knees, and at the same time strengthen the muscles in her thighs, in her calves, and in the hip and buttocks area. Another aspect that we need to also work on is balance. Okay, many patients with total joint replacement have deficits of balance, and we need to work also to regain that. And one of the exercises that we do, we have you stand on an unstable surface. And first, with assistance of both hands, you start trying to balance yourself, going back and forth and going around, making circles. And that will stimulate the sensors in the joints that tell your brain where the joint is. And therefore, you can improve your balance. Then as you improve and get better, we will take one hand off and you will do the same, and eventually you will be able to do it without us holding you, just supervising you. Okay?
Okay.
You can step down now. Another aspect that is important in the rehabilitation is your cardiovascular endurance, your ability to do activities for a sustained period of time. And for that, we put you also on the treadmill or in the bicycle to make you do some cardiovascular activities, some aerobic activities, so you can increase your tolerance and your endurance.
This is fun. This one. I have one last question for you, Tony.
Okay.
How long will a patient have to continue with the exercise program after a total hip replacement?
After their physical therapy treatment program has finished, they will usually have to continue for at least 3 months with a home exercise program. But it would not be a bad idea if they would keep doing exercises for a lifetime. Not only exercises to regain strength and flexibility, but also to maintain it, and exercises to improve their cardiovascular activities.
You mean such as the treadmill and
walking and a treadmill or a bicycle. I think exercise is very important to maintain strength, flexibility, and endurance.
Thank you very much.
You're very welcome.
Very
My pleasure.
interesting.